When we consider infants less than 2 years of age presenting with fever, the prevalence of UTI is approximately 7%. The prevalence is also about 7% in older children presenting with urinary symptoms. There are many risk factors to consider when deciding which children are most likely to have a UTI. In children less than 2 years of age, risk factors include female sex and lack of circumcision in males. Infants with higher fever and longer duration of fever are also much more likely to have a UTI. Since infants cannot describe their symptoms, we rely on risk factors to determine which infants to test. For example, uncircumcised boys less than 3 months of age presenting with a fever are at the highest risk for UTI, with an infection rate of approximately 20%. Circumcision appears to matter less as infants grow, and UTI quickly becomes more common in girls compared to boys. The increased incidence of UTI in girls as compared to boys is hypothesized to be due to a shorter urethra. There are also anatomic and functional factors that predispose children to UTIs. The basic principle is that any abnormality that alters or slows the flow of urine from the kidney to the bladder or voiding through the urethra increases the risk of UTI. The most common anatomic predisposition to UTI is vesico-ureteral reflux, or VUR. Typically, the uretero-vesical junction, where the ureters meet the bladder, closes off when the bladder contracts and does not allow urine to travel back from the bladder into the ureters and kidneys. VUR occurs when this connection is not tight enough and allows urine to reflux from the bladder into the upper urinary tract. VUR is graded based on severity. Grade 1, or mild VUR, occurs when the reflux only fills the ureter. Grade 5, or severe VUR, occurs when the reflux is so severe that it causes dilation of the ureters and renal collecting system. This retrograde flow allows bacteria to grow and cause infection in the upper urinary tract. The risk of UTI and renal scarring increases with increased severity of VUR. There are many other anatomic anomalies that may predispose children to UTI. If there's an obstruction or narrowing anywhere along the urinary tract, urine will pool before the narrowing and the child is at increased risk for UTI. Some common obstructions include ureteropelvic junction obstruction and posterior urethral valves. These conditions will often be diagnosed with ultrasound. In the absence of an anatomic obstruction, children are also at increased risk of UTI if they do not empty their bladders normally. Neurogenic bladder refers to abnormal innervation, such that the muscles of the bladder and the urinary sphincter do not coordinate properly, and the bladder cannot empty normally. Children with this condition will often retain urine or do not empty their bladders fully when voiding. Neurogenic bladder may be secondary to conditions affecting the lower spinal cord, such as myelomeningocele or spinal cord injury. Incomplete bladder emptying can also be secondary to constipation. As a result, constipation is a common cause of UTI in children.